50% of patients are symptomatic, 50% found on routine or accidental screening. A common symptoms often manifest over many months or years and include the following: polyuria, polydipsia, pruritus vulvae or balanitis, weight loss, tiredness, blurred vision, hyperglycemic non-keratotic coma, with severe dehydration or hyperosmolality. Rare manifestation, generally no signs are manifest. A patient may present with the following: obesity, foot ulceration or infection, rare in children, diabetic retinopathy or peripheral neuropathy, rare in childhood. Signs of secondary causes of diabetes, e.g. acromegaly, Cushing's disease, thyrotoxicosis, blood glucose measurement, random capillary/venous blood glucose concentration, mg/dl in symptomatic patient is diagnostic, 2 random values or any. Fasting value mg/dl is also diagnostic. Glucose tolerance test, needed when diagnosis in doubt. After a 3-day high carbohydrate, g/day, diet then overnight fast, patient takes 75 g glucose. Solution: plasma glucose is measured before glucose administration, then every 30 minutes for 2 hours. Plasma glucose interpretation: greater than or equal to mg/dl at 2 hours and any other time. Diagnostic for diabetes mellitus: greater than or equal to 200 mg per deciliter before 2 hours but greater than 140 mg per deciliter and less than 140 mg per deciliter. Fasting is defined as impaired glucose tolerance. Greater than 200 mg per deciliter at 1 hour but less than 140 mg per deciliter at 2 hours is indeterminate and may require retesting. Measurement of hemoglobin A1c, raised concentration, measurement of iron and total iron binding capacity to rule out hemochromatosis, measurement of thyroxine and thyroid-stimulating hormone to rule out thyrotoxicosis. A glycosuria alone and blood strip readings are never diagnostic. Complications are often present in older adults at the time of diagnosis, after years of hyperglycemia, but not in children. Diabetic retinopathy only affects vision if near macula. Macular edema frequent, with major reduction of visual acuity. Proliferative effects fewer but threatens vision by vitreous hemorrhage/fibrosis, both treated by laser. Diabetic nephropathy. Proteinuria is marker for high cardiovascular risk, but not necessarily progressive renal impairment, can be slowed by vigorous antihypertensive treatment, especially with angiotensin-converting enzyme inhibitors. End-stage failure can be treated by continuous ambulatory peritoneal dialysis or transplantation. Large vessel disease, coronary, cerebrovascular, peripheral, much more. Common especially when patient has nephropathy, possibly more diffuse than non-diabetic large vessel disease, but otherwise generally similar. These, especially coronary artery disease, are major causes of premature death. Differential diagnosis. Diagnosis is not usually a problem after diabetes mellitus has been considered. However, possible errors include the following: urinary tract infection, prostatic hyperplasia, vaginal prolapse, primary polydipsia, diabetes insipidus. Treatment: diet and lifestyle. The diet should be high in unrefined carbohydrate, low in simple sugars with high fiber and low fat spread throughout the day. Patients should aim at reducing excess body weight. A patient should engage in physical exercise and resume full activities. Minimal limitations for those on some drugs include not driving commercial vehicles. Pharmacologic treatment: much weight or is seriously symptomatic, in which case diet should be supplemented by pharmacologic treatment. Sulfonylurea. These drugs increase insulin response to glucose and tend to cause weight gain. Standard dosage: Gliberty 2.5 to 20 mg orally daily, given once or twice each day. Glipizide 2.5 to 20 mg orally daily, given once or twice each day. Contraindications: breastfeeding, porphyria, pregnancy. Causation in elderly patients and those with renal or hepatic failure. Special points used only in conjunction with a diet. Main drug interactions: few of major clinical relevance. See manufacturers. Current prescribing information. Main side effects: hypoglycemia is common. Otherwise, occasionally. Rashes, jaundice, headache. Biguanide. A metformin reduces hepatic gluconeogenesis and probably decreases carbohydrate absorption. Standard dosage metformin, 1 to 2.5 g daily in divided doses. Contraindications: hepatic or renal impairment, creatinine greater than 1.4 in men or 1.3 in women, heart failure, pregnancy. Special points: does not cause hypoglycemia, may rarely cause lactic acidosis, should be discontinued 2 days before and 2 days after any radiologic study using IV contrast. Main drug interactions: alcohol dependence may predispose to lactic acidosis. Main side effects: flatulence, anorexia, diarrhea, sometimes transient. Insulin. Insulin is indicated for symptomatic or uncontrolled diabetes mellitus despite maximal oral agents in addition to diet. Usually, it is needed only once or twice daily. A longer-acting formulation may be used to control basal hyperglycemia. See diabetes mellitus, insulin dependent for details. Other options. Acarbose 50 mg 3 times daily, alpha-G. Daily, alpha-glucosidase inhibitor, decreases rate of glucose absorption, thereby reducing postprandial glycemia. Recent introduction. Atroglitazane increases peripheral insulin sensitivity. Recently introduced little experience in children. Treatment aims to restore normal well-being, to achieve optimal glycemic control without significant hypoglycemia, to provide patient education and self-care, to prevent complications.